Good evening. I'm Bill Curtis. Welcome to the 14th Annual Northwestern Institute for Global Health event. A year ago, when we gathered virtually due to the COVID pandemic, I closed out our program optimistically, noting that I'd be back as your host in person this year. But with the virus still with us, the necessity to remain respectful of one another led us to decide to once again share the story of the Institute by joining together online instead of in a hotel ballroom. We have all felt the impact of the pandemic in ways large and small. And although it kept many of us away from our offices, the work never stopped for our doctors and nurses and medical staff, frontline caregivers, and behind-the-scenes researchers. Nearly 2 years later, they are as tirelessly committed as ever. And we know that we have been the fortunate beneficiaries of their special dedication to the wellness of others. The pandemic did not impede the urgent work of Northwestern's Institute for Global Health. In fact, it redoubled all its efforts, expanded the number of centers and programs and research projects, and extended its reach to even more countries around the world. The Institute's interdisciplinary team has continued leading the way on understanding COVID-19 and fashioning the tools needed to counter it now, but even more critically, to be ahead of the next mutation, the next virus, so that it might not be able to threaten lives and livelihoods in such a devastating fashion again. Coming up, we'll be sharing all of it with you in a 30-minute mini-documentary tracking the Institute's interdisciplinary team, followed by an opportunity to have some of your COVID questions answered by our Institute experts. But first, as always, it's my privilege to introduce my personal primary care doctor, who made sure I am fully boosted and flu immunized. He is also the Deputy Director of the Institute for Global Health, Dr. Robert Havey.
Thank you, Bill. On behalf of the Institute for Global Health, I'd like to thank all of you for taking time to join us tonight. Since many of you may be watching for the first time, a little background may help set the stage. Our work goes back 15 years and even more, when we started an effort to help educate our medical students by sending them abroad to over 42 countries. They served the poor and needy and learned lessons of compassion and responsibility and commitment to the human family that just couldn't be taught in the classroom. We knew the complexity of healthcare in today's world required that physicians develop a global perspective, and our global health rotations helped prepare them for their changing roles. Along with student travel, we've been aggressively expanding our other activities. We're funding research projects to find sustainable ways to improve health around the world. We're expanding education programs to train the global health leaders of tomorrow. And we're developing programs to help care for patients in limited resource settings. We understand how exhausted everyone is from the effects this pandemic has had on our lives, and we're all anxious to see things get back to normal. In fact, because of this COVID burnout, it may be easier than ever to turn a blind eye to all the other health problems in the world today. But the reality is that the world's population keeps expanding, growing from a population of 2 billion when my father was born to 8 billion today, with a further increase to 9.5 billion people in the next 25 years. How will this affect the world our children inherit? The reality is that pandemics like COVID will occur again, along with multiple other infections, both old and novel, all being easily transmitted around the globe. How do we become better prepared for this certainty? The reality is that non-infectious problems like heart disease, diabetes, cancer, and neurologic diseases, along with infant mortality and diseases of aging, all are worsening, threatening the quality and longevity of billions of lives. How do we help parents have healthy babies? And how do we add life to years rather than just years to life as we age? In short, it's clear that global health problems are not going away. And despite the fatigue all of us feel after the past 2 years of intense, nonstop effort, we know there is no room anytime soon for complacency. Someone just has to continue to do this work. Tonight, we hope you'll enjoy the beautiful video produced by Donna LaPietra and Bill Curtis. Their team spent several months interviewing many of our talented Global Health Institute members to assemble a sampling of the past year's activities. So now sit back and join us as we watch this year's video update on the Institute for Global Health.
It hasn't been easy these past 2 years. In a world already challenged with record population expansion and growing global health needs, the COVID-19 pandemic has created what at times seems like insurmountable problems. With over 500 million people having been infected with COVID-19, with 5 million of them losing their lives to the virus, with families being upended, depression cases soaring, childhood development and education facing unprecedented setbacks, and with economies devastated and poverty rising, the work has been hard and complex and exhausting. But even in the face of the most daunting challenge the human race has confronted in a century, amazing advancements have been made in science and medicine. Vaccines have been developed for a disease that was unheard of just 2 years ago. Variants of that disease are being tracked in real time, with technology developed faster than anyone could have possibly imagined. And among the seemingly endless stories of heartbreak, there are also stories of resilience, discovery, and perseverance. This is one of those stories, about an organization doing its part to meet this challenge and all the challenges yet to come. A group of scientists, researchers, and clinicians growing in strength and number and making a bigger impact on the world every day. This is the story of Northwestern's Institute for Global Health.
The Institute for Global Health is a very collaborative, heterogeneous group of medical academics from a variety of fields whose main purpose in being in the Institute is their global activities. Global health now really constitutes a variety of sub-disciplines.
You know, as we've grown, we've really looked at all the things that are needed around the world in global health. I try never to lose sight of the fact that we are very lucky here in the United States. There's a frustration when you see all the need in the world that you're not scratching the surface in many areas yet.
What started as an organization supporting global health rotations for medical students has expanded into a world-class institute, encompassing 9 centers, still emerging programs, and hundreds of dedicated researchers, doctors, scientists, engineers, economists, and educators.
Everything we do with global health has to do with the kind of root of providing health care. You can't provide health care if you don't have treatments, and you don't get treatments without research, and research leads to scientific discoveries that improves treatments. You don't have health care if you don't have good health care providers from every level of the curve, including the physicians themselves.
In the wake of the COVID-19 pandemic, the dire need for collaboration in the healthcare world was drawn into clear focus.
The Institute for Global Health is very important for all of us because it gives us a platform to interact and collaborate on various global health projects, cardiovascular research, cancer research, primary care, for example, but these are all interconnected.
We're in the engineering school here. With the Institute for Global Health, we rely on our colleagues in the medical school and in the College of Arts and Sciences to help with many of the projects. So that kind of collaboration between McCormick, Weinberg, Feinberg, and Kellogg is really what has driven us. We know each other personally, and we trust each other.
While we have rallied the Institute's resources to combat the effects of COVID-19, we understand that nothing in global health happens in a vacuum. Using new tools we have developed during this struggle, we are finding new answers to persistent health problems.
It's really been a massive growth spurt. Because of COVID, we were able to pivot our research focus.
The Institute has taken the COVID pandemic and launched hundreds of projects, collaborated with hundreds of countries. We have discovered more things about population health, about microorganisms, about genomics in record time.
Making products, we're training people. People realize, this global health is a much bigger thing than we had originally thought. We really are making a mark in the world.
In the Center for Global Communicable and Emerging Infectious Diseases, we're focusing on two critical goals for today's world: advancing our scientific understanding of diseases, old and new, and preparing the next generation of global health leaders to better combat them.
I think we set a lot of the groundwork, I think, for a lot more sort of innovative research in terms of drug discovery and treatment trials and things like that. We now have a cure for hepatitis C, and we really hope that one day that hepatitis C will be eradicated. And as I mentioned earlier, we're working on now new treatment trials for hepatitis B and potentially curative agents, which hopefully one day hepatitis B, another scourge of the world. I think larger goals of the program, we're very much interested in, obviously preparing that next generation of global communicable disease leaders. For the center to be successful, we really need, a lot of people involved, and it's global health research. So you absolutely need your folks here on the ground, your global health partners. And it's not just one discipline, right? You need lots of people involved from several different areas, whether that's at the sort of institutional level, at the policy level, at the basic science realm.
Dr. Pablo Pedaloza is working to learn how the body's immune system responds to infections, but collaborating with doctors who provide clinical care for infected patients has dramatically enhanced his own research.
So this unique ability to interact with these clinicians and get samples, I think is critical because it makes you generalize your observations doing basic science to more of a translatable field. The future proposed work is trying to look at what is the innate cytokine signature following vaccination, following COVID vaccinations. After vaccination, we want to understand what is the quantity of the antibody response. So we're trying to understand what is the early cytokines that are correlated with improved outcomes, improved responses with COVID-19 vaccines. So what this is showing is that if you vaccinate animals with a SARS-2 vaccine, you also get SARS-CoV-1 specific responses, you get responses to common cold coronaviruses. That suggests that a universal coronavirus vaccine may be possible based on the genetic conservation between SARS-1 and SARS-2.
Dr. Mamadou Maiga is trained in biomedical engineering, medical microbiology, and immunology, and is working on training the local scientists in Mali to perform genetic sequencing in their own country so they can study the behavior of COVID variants in their local populations.
When the pandemic started, and it was on virology and clinical study in Guinea and Mali, to look for circulating variant to describe clinically how the disease is presenting in patient in Mali, in Guinea. The next step on that project now is to develop the local capacity to do whole genome sequencing so that we can identify variant, which is important in a country like Mali with low resources. So we are moving now from bringing sample from Mali to develop local capacity to do the sequencing on the ground by local people.
The Institute's Center for Innovation in Global Health Technologies leverages the abilities of researchers and engineers to develop new tools to detect and analyze health issues.
With the COVID pandemic, our efforts have shifted to develop novel diagnostic devices and technologies for COVID-19 specifically.
One of the most promising results from those efforts is DASH, a device that can be used to detect the presence of COVID-19 in a subject within just 15 minutes.
We're really proud of DASH. It is a homegrown technology that was developed by our collaborators in the engineering school up in Evanston. DASH actually stands for Diagnostic Analyzer by Selective Hybridization, meaning it's just a device that can analyze really any specimen to see if we can find a target of an infectious disease within that specimen that you're putting within the technology.
The DASH technology is not an antigen test, but instead is an actual PCR assay, which provides far more accurate results. But unlike PCR assays in other labs, this machine is portable and gets results in just 15 minutes.
We'll be developing assays for all these other diseases, HIV, TB, sexually transmitted diseases. This is our vision for diagnostics in low resource settings, places where the poor people of the world live, is that it needs to be as good, as accurate as what we have in the big labs.
And we know how important that is for COVID, to be able to identify people very early in their course of infection. And so we think with the accuracy of a PCR technology, but the speed of an antigen type test, that's what comes together with our DASH technology. And so this would be a major advance in the field of diagnostics.
While we develop new methods to detect the presence of COVID-19 and other diseases in the Center for Pathogen Genomics and Microbial Evolution, we're deepening our understanding of those disease structures and how they spread, both improving our ability to combat them and to predict their movements.
It was started by studying bacterial infections. Why does one bacterium cause severe disease and its neighbor, that infection is cleared very quickly? And so by looking at the genomes of this bacteria and comparing them to each other, then I could start to answer some questions. When COVID hit, I saw that the work that I've been doing in bacteria of sequencing their entire genomes could also be applied to viruses as well, specifically to the coronavirus. And so we were able to take the skills and the techniques and the equipment that we had and very quickly adapt them to sequence coronavirus as well.
So this is our RNA extractor. So what this does is it takes the samples, the specimens that have the virus in it, the ones that came from the nasal swabs, and it extracts the nucleic acids, the RNA from the virus that's in those specimens. DNA from that is prepared from the viruses is loaded onto this chip, and then it flows through here, and the instrument then can read the individual bases from the individual viruses and recreate the entire genome by doing so. We saw that there were some differences in the viruses that we were sequencing here in Chicago compared to other places in the world. We saw that there were certain variants of the virus that had already developed. They were producing more virus over time, that even relative to some of those earlier versions of the virus.
Understanding the gene sequence of a virus is the key to unlocking treatment, tracking virus development, and with enough understanding, keeping viral outbreaks under control.
In all of human history, we've been able to eradicate one virus, and that is smallpox. I think it's probably unrealistic to think that we're going to completely eradicate COVID virus. Our goal as scientists and as clinicians is to minimize the misery and minimize the suffering of it, and do whatever we can to safely reach that point that virus becomes more background. We are not sitting still. We're continuing to move forward, continuing to do research, continuing to work with clinicians and scientists together with public health experts and with the communities to really do our best to get through this together.
Though we have pivoted so many of our resources in the effort to halt the effects of COVID-19, we still must contend with the continuing presence of other health complications. Heart disease remains the most prevalent health issue around the world. The Center for Global Cardiovascular Health works to understand these problems and to combat them through research and education.
Heart disease is the leading cause of death all around the world. 1 out of every 3 deaths is due to heart disease. Surprising. We know exactly what to do to prevent or postpone thousands, millions of these deaths. What our center is interested in doing is trying to implement strategies, policies, systems, and interventions to be able to help people improve their cardiovascular health and to improve cardiovascular health care.
Partnerships are essential to global health work. Finding a strong partner on the ground, either a cardiologist or a researcher who can partner with you, is key to starting kind of new sites.
For example, a project that I co-lead with the University of Abuja is we're integrating hypertensive services into primary care across 60 public primary healthcare facilities in Abuja, Nigeria. This is allowing for the very first time patients living in Nigeria to be accessing high-quality hypertensive services in their own communities.
Research and education alone can't solve every problem. Implementation of those health strategies is necessary to ensure that the efforts that have gone into creating a solution find their way to actually treating a patient's health issues.
My research from my NIH Fogarty Fellowship demonstrated that a quality improvement toolkit could increase rates of these life-saving medicines in the subset of patients with heart failure in India. Less than half of the patients were receiving these medications that we know can save their life. That is what inspired the concept of a polypill, where we combine up to 4 medications into 1 pill to improve patient adherence. This is a concept that's been successfully used in other conditions such as HIV, high blood pressure, and we're translating that idea to try to improve care for patients with heart failure.
While our core of researchers and clinicians are unparalleled in their understanding of the science, biology, and physiology of healthcare issues, the Buehler Center for Health Policy and Economics provides them an invaluable resource for turning their findings into actionable results.
I went to the very first meeting of the Institute for Global Health. Everybody was focused on disease, procedures, people who are mapping the genome. Those are all really important things too, but I saw a big need for health policy. So we can also inform and help other investigators and other center directors by helping them with economic questions. So like when they're writing their research aims for proposals, we can tell them the cost efficiency, the benefit of it.
The center informs our research with critical data about the settings we are working in. The importance of that information cannot be overstated, especially when health issues must be addressed on a global scale.
I work on Feed the Future countries, which are countries that are low income, that have high rates of food insecurity. And so I've been working on that one for years. And then when the pandemic broke out, the program officers at USAID asked me if I could pivot towards COVID. So I'm not an infectious disease doctor. The best thing that I could do would be surveillance. So I developed a surveillance system, but also a forecasting model. And from there, it went to a full interactive dashboard on SARS-CoV-2 surveillance. And on a daily basis, we conduct surveillance on more than 200 countries around the world. Guatemala, Honduras. I can run the data and I can look at just immediately and find out which countries are in an outbreak, who's not in an outbreak, but who has escalating speed.
The Institute's work has broadened to encompass every facet of global health systems around the world. But while we work to address these issues, we continue our original mission through the Center for Global Health Education.
You can't learn global health in a classroom. You can't really learn global health on a Zoom call. You actually have to go there. It's been tough to travel lately, but we are still sending people abroad with our partners that we know really well, we've been working with for over 20, 25 years. Students are starting to travel again.
We aim to equip future global health professionals with the values and skills and knowledge to contribute to health and equity universally, globally. We teach about the primacy of partnership. We teach about local solutions and how local solutions are critical and how to empower our partners.
Our global health rotations are integral to the education of new physicians and researchers, allowing them to experience health systems in low-resource settings.
So the medical students stay for a month. They have an in-country doc who's educating them. They really get a feel for the country. They live among people in the country, in the local area, and they get an idea of culture. They get an idea of different ethical dilemmas that they have to deal with in country. Sometimes they come up with very unique ways of addressing problems that we might not have thought of. They're learning something different, and our students are broadening their perspective, both on medicine within the US, but then medicine globally.
But we are not just educating our own students. An equally crucial part of global health education is training doctors and physicians in these settings to better educate their own students. Dr. Colleen Font, a pediatric emergency medicine specialist, has developed a training model for medical students in Kenya, teaching them life-saving procedures which will enhance their ability to care for their own patients.
Globally, healthcare there's a challenge in many parts of the world, and one of the major issues is trained healthcare workforce and specialty healthcare workforce. So by focusing on education, we have this really unique opportunity to kind of build capacity for our peers around the world. The project that I work on, training a group of pediatricians in Western Kenya on the use of simulation to train their own medical students. So these medical students, before they graduate, have the opportunity to practice really important and life-saving pediatric skills. So now they have the experience of resuscitating a baby, which they had not had previously.
The foundation of that capacity building, no matter the setting, first starts with an individual's primary care physician. Through the Ryan Family Center for Global Primary Care, we're enhancing our focus on these crucial components of healthcare systems, both abroad and here in the U.S.
We've learned a lot of hard lessons with COVID, but I think what we've really learned, if you have a strong primary care system, which is really, all the way from promotive and preventive to curative and palliative, that really can form the platform onto which all of these other programs can be. For me, what's urgent is how do we make sure that the frontline providers are trained, are supervised, are motivated, because those are going to be the people who are going to be able to detect the next pandemic, who are going to be able to manage the next pandemic, and as we're seeing with vaccines, are going to be able to really convince people about what they need to do to, address the next pandemic.
In the Dominican Republic, the program has partnered with local organizations to build new primary care clinics to better serve the local community.
We selected this site because it's on the grounds of our partner organization, Nuestros Pequeños Hermanos, or Our Little Brothers and Sisters, that's a series of children's homes across Latin America and the Caribbean. Although Dominican Republic is considered a high middle-income country by World Bank standards, due to the sugarcane industry and many Haitian immigrants working in this industry and the bateys in which they live, there's a large underserved population, many of which do not have access to basic medical care. What sets us apart in primary care, I believe, is the sustainability that we can offer with a local team on the ground, providing follow-up care to the patients. So here in our primary care clinic, when it's operational in early 2022, we'll offer all types of primary acute care and preventative care. Hypertension and diabetes management, checkups for children. We'll have an imaging room where we can provide patients with x-rays and ultrasound. We have a minor procedure room. We have a pharmacy that can provide patients with most kinds of medications that they'll need. And we'll have a laboratory that will provide patients with different kinds of blood work to provide their correct diagnosis.
Building those foundations is critical to the improvement of healthcare systems. But as we improve health access around the world, we need to do even more to improve all health services. Worldwide, surgical care that would easily be available in the U.S. is out of reach for over 5 billion people. Through the Center for Global Surgery, we are working to make these life-saving procedures available to everyone, no matter where they were born.
Only 6% of all surgeries worldwide occur in low-resource countries. There is a large percentage of patients, 5 billion, that don't have access to urgent and emergent surgical care.
And that means very basic conditions, everything from appendicitis to blocked intestines. Those conditions become lethal when they're not treated adequately. Many children and babies around the world are born with correctable surgical anomalies that with a single surgery, they could return to normal life.
Surgical repair of fistulas, a common procedure in the U.S., are often unavailable in the places where they occur the most.
Fistula just means a connection between two things that shouldn't be connected from obstetric injuries. 95% of vesicovaginal fistulas occur in low-income countries, low-resource countries. We go in and evaluate patients that have injuries from childbirth that really the country doesn't have the resources to repair, or the physician's able to repair them. These injuries are very devastating. The women, and many of them are repairable injuries.
But while we can work to help repair these injuries after they occur, preventing them from occurring altogether is the true key to ensuring health equity for these populations.
We developed a cesarean section education program for obstetrics and gynecologists in Rwanda. And we have a team of OBGYN physicians that will work with the physicians in Rwanda, teaching them good practice, good skills, try to really decrease the occurrence of fistulas at the time of surgery, but also to help prevent them by surgery by doing C-sections and preventing prolonged labor.
So that's where the Northwestern Center for Global Surgery comes in. We can really facilitate some of the implementation science around this. We can really help provide the training and education that's needed.
In addition to global surgical care, access to oncological care for the treatment of cancers is also uncommon in these low-resource settings. The work of the Center for Global Oncology focuses on improving access to treatment for one of the most concerning issues any person can face.
We know generally cancers, if you detect them early, it offers a huge opportunity for improving outcomes.
Dr. Jonah Musa is using technology in Mali to collaborate with researchers and doctors around the world to help close this gap.
The Center for Global Oncology is really helping in achieving this objective. So one of the areas that they have helped support us is the area of telepathology.
Through telepathology, clinicians can use communications technology to collaborate with other researchers and doctors anywhere around the world, especially here at Northwestern.
I could see a patient who has a suspicious cervix, and we can scan the image and send it to our faculty there at Northwestern, and they can look at it and give us feedback on the appropriate diagnosis. It has helped to improve our diagnostic precision for cancer here in Nigeria.
Neurological care is also a sector that remains out of focus for so many people around the world. Through our emerging program for global neurology, we're expanding our studies of the body's nervous system to countries that would otherwise never have the opportunity to work with such an important part of our health.
Global neurology is to provide access to neurological care everywhere in the world. We send neurology residents every year for a 1-month elective in resource-limited setting. It's very rewarding work.
But though the program is still growing, it is already studying one of the most important issues in recent times. The long-term effects of the COVID-19 virus are still just being understood. In particular, its effect on the body's nervous system can be catastrophic.
In March 2020, from a publication coming from China, we understood that COVID-19 was also going to affect the nervous system in patients who are hospitalized with COVID-19 pneumonia. We created a neuro-COVID research group, and we started to look at our population of hospitalized patients in COVID-19 in March 2020 to April 2020, and we studied the first 509 patients who were hospitalized in Northwestern medicine. And we found out that 82% of those had neurologic manifestation, and the most severe of those was encephalopathy, which is basically a dysfunction of all brain function. And we opened one of the first neuro-COVID-19 clinic in the United States.
Dr. Korolnik's research into the neurological effects of COVID-19 will allow the Institute to share these new discoveries with our growing network of under-resourced global partners.
How can you see all these problems around the world and not try to tackle them? Someone has to do this work.
Our goal here is really to avoid any kind of one-off situation, going to one place, doing one thing, and then leaving. That was kind of the old-fashioned way of global health. There has to be something sustainable.
Those sustainable solutions are made possible through the work of this interdisciplinary institute and the support of thousands of generous donors. Now, we have entered a new era of global health advocacy with the naming of the Robert J. Havey Institute for Global Health.
We saw the great work that he was doing in the Global Health Institute, and we saw that the training that they were providing to medical students and really doing critical work.
In the process, they learned about looking at the whole person and the families from which they came, in the worlds in which they lived. It's the whole physician. It's not just a specific issue. And this is something that represents Dr. Havey's practice.
The $25 million naming endowment is a gift from Pat and Shirley Ryan, allowing the Institute to have the guaranteed support it needs to further expand its mission of advancing human development around the world through quality healthcare. With an additional gift of $10 million, the Ryans have established the new Ryan Family Center for Global Primary Care within the Institute to strengthen primary care systems in low and middle income countries.
Northwestern's a quite unique, connected university. Faculties work with each other. They collaborate. They've broken down all the barriers that may come with academia.
That as we train more young physicians, as we get more scientific research, it just multiplies. And there's the ripple effect, the multiplier effect. And our goal in making the gift was to see that Northwestern University is the leader in global health solutions.
COVID has allowed us to develop new tests and new understanding of viral mutations, viral treatments, and vaccinations. And we've learned a lot, but at the same time, we've learned that as the world gets more complicated, we're learning how to manage everything at once. It's a tall order.
To match the ever-growing needs of an ever-growing population, individual endowments to each of our centers are necessary. There are so many facets to healthcare, each of which needs the dedicated support and attention that would enable our researchers to find unprecedented solutions to the problems that have plagued our civilization for centuries. And importantly, the problems that will arise in the years to come.
As we moved into the pandemic, the COVID pandemic, it just became clear that this was a global problem, but it was a problem that was likely to repeat itself.
The pandemic is going to end, but what are we going to do to prevent the next pandemic? That's what we have to think about.
These insights into the work of the Institute for Global Health mark neither a beginning nor an ending. They are just one snapshot of the ever-evolving work being done to further our goals. Healthcare access, research and scientific discovery, quality improvement, and medical education.
I see what good healthcare can do for a human being, and I think about areas of the world that don't have any of this. Fortunately, we've got a huge talent pool. It's pretty impressive that the more we expand and the more we continue to hold ourselves together under the umbrella of this one institute, the amount of work we can do and the scope of what we can do just keeps expanding. That motivates all of us every day.
And as this is one moment in the evolution of our institute, so too is this just one moment in time for the needs of people across the globe. We continue to address the healthcare needs of every human being. From worldwide pandemics to persistent health issues, to all of the challenges yet to be discovered, and those yet to be answered. While these are just singular moments, what persists is the dedication of our researchers and clinicians. What endures is our collaborative process and teamwork. And as these moments pass us by, one constant remains true. This work must continue so that together we can all continue to make a world of difference. I hope the film documenting the work of the Institute answered some of your questions, but also raised others, because this is the portion of our program when joining me is Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health, and Deputy Director Dr. Robert Havey, to answer your Institute and COVID questions. We've already received many of your questions, but you can still participate. Just use the Q&A feature on your Zoom. Let's get underway. First question to Dr. Murphy. What do we know about the rate at which the immunity from the Pfizer vaccine declines?
Well, we know this, that it holds up pretty well, but at 4 months, something begins to happen. The antibody levels start to decline very slowly. That's one of the protective effects. But the hospitalization rate with breakthrough cases that end up going into the hospital actually gets worse. So it goes down to about 71% compared to like up in the 90% originally. There have been multiple studies. Some say it works out to 6 months. The Israelis say it drops down to 40%, but it does start to decline. And that was just enough to give the FDA the data to say, look, time for a booster.
So there was the Kaiser study that Rob and I talked about that just got published. A huge study, 3.5 million people who were vaccinated between December last year and August this year. 1 month after vaccination, there was about 90% efficacy of preventing COVID. But 5 months later, it was 47%. So that, along with all the other studies, including Israel, showed the vaccine efficacy does drop.
Were you disappointed or surprised at that?
Oh, I don't think I could say I was either. You know, these are game time decisions. These are new things we're learning every day. So I don't think you can use the word surprise or disappointment because we're learning as we go along.
Will we always have to have a booster? I mean, every 4 months?
Well, that's a good question. We won't know. We won't know until 4 months from now. So it's, of course, being looked at very closely.
Yeah. And how many boosters?
That remains to be seen. It may be every year you need a booster. It may be more than that. With pneumonia, you know, it's every 5 or 10 years. Mm-hmm. With the influenza, the flu, it's every year we get a new vaccine. So it remains to be seen. We're learning as we go.
What is the significance of the new malaria vaccine?
Oh, the malaria vaccine. Well, this is a pretty big breakthrough. Now, malaria is a killer of children, especially under 5 years of age. And the vaccine is not perfect, but it's the first vaccine against a parasitic disease. So that's a giant breakthrough. That, coupled with bed nets, is going to give a tremendous protection for malaria.
Bed nets?
Bed nets.
Yes, yes.
Treated bed nets, sleeping under a bed net, we've known for a long time, is very effective, but it's not necessarily practical. So it looks like it's kind of in the same category of effect as the bed nets, and together, of course, they work better. And they estimate that this vaccine actually will prevent 5.4 million infections per year and maybe 23,000 deaths. So it's definitely a step in the right direction.
It's one of the big breakthroughs,
it's
I would think. Anybody who's been to Africa knows.
Yeah, absolutely.
What a fear, what a fear.
Well, kids get malaria, 3, 4, 5, 6 times per year.
Yeah. Dr. Havey, what are some of the biggest challenges that the world faces from the global health standpoint?
Oh, there's so many. You know, I don't want to beat a dead drum about population explosion, but, we can't ignore the fact that the world gets bigger and bigger and bigger, and that you've got a lot of people, and that itself poses a challenge. You've got urban sprawl, and people think people don't live in cities anymore because of some of the things that have happened the last few years, but most of the world has moved to cities, and that's going to increase. There's a huge proportion of urban slums because of the urban sprawl. There's persistence of infectious diseases, of course. COVID's shown us that. You know, there's an interesting article in the New England Journal about 50 years ago where the authors said because of the advent of advanced antibiotics that we no longer needed infectious disease doctors. That was before HIV, certainly before COVID. And we started saying, hey, things like heart disease are more important than communicable infectious diseases. And now we know we can't let our guard down about either. So we have an expanding population, more urbanization, climate change, infectious diseases that were just starting to get us worried about SARS and then Zika and Ebola, but now COVID. Look what it's done to the world. And then an advancing population with age that we have to deal with. How do you age well, and how do you prevent heart disease and neurologic disease and this increasing amount of diabetes and obesity throughout the world? So when we say what are some of the global health problems, the list is endless.
Dr. Murphy, what do we know about the origin of COVID-19 and how can that help us by understanding it?
Yeah, that's a great question. Coronaviruses have been around for a while. They affect multiple species. There's now the 6 that affect humans. And, it's a matter of time before another coronavirus actually jumps into and infects and causes disease in humans. That or yet another virus. As far as the origin of this particular virus is concerned, recent evidence has shown that it is very closely related to the coronavirus that they find in bats in northern Laos, Thailand, and parts of China. And that's very closely related. That is very strong evidence that this disease, what we're dealing with now in humans, came from an animal reservoir, probably bats, but maybe pangolins or some other animals that were sold in markets across China. And that's where it came from.
And with intercontinental travel, they can be around the world before you know it.
You can be in Chicago, within 12 to 15 hours from pretty much any place in the world. So people move around. They haven't been moving around in this past year, but that will start up again.
Yeah, when everyone thinks that the coronavirus is something that came from nowhere and will go back away, they forget that the virus is not a new family of viruses. Ironically, starting in June, when COVID was dying down before the summer surge, I had literally hundreds of people coming into my clinic with respiratory infections. About 25% of them had coronavirus, not COVID-19, the old coronavirus. They had a cold, but it was a coronavirus. So it wasn't hiding in a lab somewhere. It just came back out like colds do when people start to mingle and mix again.
Did you suddenly wake up one morning and say, wow, I got a new problem?
No, I mean, the other viruses have always been there. And in fact, we have a tracker at Northwestern that we publish every week that shows the number of viruses that we identify every week. And that tracker was flat for 15 months, except for COVID. Flat. You saw nothing except COVID. Now, RSV, coronavirus, rhinovirus, adenovirus, para-influenza virus I had last week, they're all coming back.
Wow. Dr. Murphy, what are the pressing needs of the Institute?
Well, right now, we've gotten a very generous gift from the Ryan family, as you know. The Institute is now endowed, and our Center for Global Primary Care is taken care of, is endowed. We also have one endowed professorship in molecular epidemiology, which will help studying where these viruses come from and where they're spreading. We need more. We need more of these professorships for each center, and we need the other 7 centers to be funded.
And your plans for the future for the Institute, do they include opening the doors and welcoming everyone?
Oh, absolutely. Fortunately, because we've basically been in the business for over 20 years, we have great relationships around the world, our faculty here. And during this whole pandemic, with none of us leaving the campus here in Chicago, we were able to keep all our existing programs going full speed, using Zoom and Skype and whatever kind of communications we have. And we've trained the people over there, and they were able to continue the work that we had started. We even applied for new grants with them, and were awarded in some cases.
How do you foresee global climate change impacting the health of the world? We've already seen 5 million people die from the virus.
Well, what it's doing, what the global warming is doing, which one was talking about climate change, it's really global warming. What that's doing is expanding the tropical areas and subtropical areas to places that never had to worry about dengue fever or Zika virus or whatever. That is really going to change things. So we're going to see that already. The southern part of the United States is a subtropical zone. The tropics actually start south of there, south of the United States. But we're going to see an expansion of the areas where these diseases are impacting.
Well, what are the most exciting developments that are coming out of the Institute?
Well, some of the most exciting things are the work we're doing in the genetics of the coronavirus, figuring out what strain it is, what's causing what. We're doing evaluations of the coronavirus vaccines and how to communicate better with our project called CoVaccin, because it's more than just having a good vaccine. We have good vaccines. Everybody took the vaccine, there would be no more pandemic in the United States. But we can't even get 42% of the people to even take the vaccine. So it's not good enough just to have a good preventive product. So that's another thing that's actually working out quite well right now.
These numbers are really important because it seems like we don't hear them enough. How many people have received the vaccines, and how close are we?
In the United States, 58% of the population is fully vaccinated. Yeah, FDA approval and CDC approval has happened for the children 5 to 11 years of age with the reduced dose Pfizer vaccine. So that'll be a big help because the kids are also spreading it too. And by the beginning of next year, we're likely to see 6 months to 4 years actually get approval. That's the track that they're on. So kids get a lot of vaccines before they go to school. Coronavirus vaccine is going to just be another one of those vaccines. We have to get up to 90% or so, somewhere in the 90% range before we're going to be able to control this thing. The other thing that's going to have to happen is the vaccines are going to have to be tweaked. Because if we get another variant like Delta, there's already Delta Plus in the United Kingdom that's got 2 additional mutations on it. There could be something worse that comes. We have got to be prepared to make and test those vaccines and get them out to market. Now, we've already done it once. When the whole vaccine development started, not one infectious disease person, myself included, thought a vaccine would be available and put into human arms in the year 2020. And we were all wrong. And that's incredible because the technology is so good today. And we're going to have to do the same thing when the next bad variant comes around. And this time we'll be more prepared.
Yeah, we have to remember when we talk about the breakthrough of the vaccines that it didn't just happen in the 2 years because we really went at it. It happened as a building block because of our understanding of the previous SARS viruses. We showed in our event last year, Dr. Carla Satchel, who runs the Center for Structural Genomics here at Northwestern, and she knew the structure of the SARS-1 virus perfectly. And she's the one they turned to after the preprint came out in January 2020, and within 48 hours knew the structure of COVID-19. That's what led to the vaccine because we identified the spike protein. Think of what the vaccine does. It tells your body to make spike proteins. How could you develop a vaccine like that if you didn't know that that was the target? We knew that 20 years ago, and we built it up. And that's the lesson of science building upon science.
And why some people are so scared? Why do they not want to get them?
Well, I think a lot of the reason why people are afraid that I hear is when they hear the term EUA, Emergency Use Authorization. That scares a lot of people. Now, emergency use authorization is what it says. There's an emergency and you can use the vaccine before it's fully approved. All the testing has been done on 25 to 50,000 people per vaccine. Those patients are continued to be followed. All the testing in the animal, and the test tube, and the tissues, all that has already been done. This is not a testing thing. This is a use thing. Typically, the FDA requires the vaccine manufacturers to wait a whole year after the development process before they get the full approval. The only one that has gotten that so far, because they were first, is the Pfizer vaccine, because they were the first ones out of the block. And so they have full approval for adults, 18 and over. So there's no emergency use, nothing like that for everybody over 18. As the clock continues around the year, you'll see full approval for Moderna, full approval in the teenagers, full approval in the children.
There's 2 other reasons why there's been such vaccine hesitancy in the United States. One of those is the absolute flood of information. Some of it just plain old wrong. I mean, there's good studies suggesting that 7% of the websites you can visit about the vaccines are full misinformation, just completely false, and yet they get more visits than visits to the CDC and NIH websites combined. So people flock to misinformation for a lot of different reasons that would be just too complicated to explain. But the other reason, besides the EUA concern, is that there is a visceral reaction from some people against who's telling them to get the vaccine. And I fight that every day in my clinic. I tell my patients who have not yet been vaccinated, trust me, trust the science, trust the doctors. And actually, they all say that they do once you get them one-on-one. But when a particular public person in their region tells them to do something, they sometimes have this anti-authority pushback, which is just disappointing, and it has slowed it down. It's led to the hesitancy. And so my argument's always been, get this in the hands of the medical professionals to promote and disseminate information on and explain to their patients one-on-one and get the acceptance that way.
You know, this month marks 5 million people dying from COVID worldwide, 740,000 in the United States. Of the top wealthy countries, 8 wealthy countries, we account for 50% of all the cases. And we're not 50% of the cases that have died. Mm-hmm. The United States is the country with the most deaths in the world from COVID. So something has really gone awry here that we really have to work very hard, and the Institute will work on this, to help people understand, get them the right information for them to make the decision that can be life-saving.
Well, if 5 million people have died worldwide,
mm-hmm.
how many have died from the vaccines?
Basically a handful. Single, double digits at the most.
You'd think we'd be able to understand that, don't you?
Well, this is one of those things where if there is one death, it's tragic. It's nothing short of a tragedy. It's almost a war analogy. There's going to be a battlefield mentality where you're going to win the war. Most people are helped. Most people survive. It's made a dramatic difference, but there are a few people who have unpredictable reactions. You just can't focus on that. Not that you don't care about it. You study the heck out of it. You pause vaccine implementation and distribution until you understand it. You do everything you can to ensure safety, realizing you're still going after billions of people to protect.
How did we develop the vaccine so fast, so quickly, both at the institution and among researchers of medical science?
Yeah. Well, the messenger RNA technology was there. That's key. I mean, we knew the structure of the protein. We knew what the RNA sequence was, but the technology to take a little piece of messenger RNA and put it into somebody to have them make the protein. You know, I tell people this is as if you knocked on the door of a factory and you handed them a work ticket and you told the factory to make spike protein. That's what that's what the mRNA vaccines do. The factory just makes it. That vaccine, the mRNA vaccines, do not get into the nucleus of your body. They don't get into your DNA. They are a work ticket. They tell your cells everywhere to make the spike protein. So we had to have the technology to do that. We had to be able to put it into a particle that would at least allow it to get into the arm and then start getting through the bloodstream and have the body make it. We had to build upon the science of 20 years to show us what coronaviruses look like.
And within 24 hours, you said you had the picture of what it looked like.
We had the picture in 24 hours, and we identified the target. And look, it was everybody's best guess that going after the spike protein was the best thing to do. We could have been wrong.
Yeah.
We weren't. We were fortunate that way.
We underestimated the effect of the mRNA vaccines. I mean, if you remember at the beginning of the whole vaccine launches, you know, people thought, oh, if this is at least 50% effective, it will be acceptable. Mm-hmm. And it was 95% effective. It really blew everybody's mind. We are really, really lucky.
What's the current research on people who have had COVID, either with or without being vaccinated, as far as the length of the immunity and whether, I know we've answered this question, whether the additional boosters are needed?
Yeah. Good question again. The immune system is very complicated and has two major components. One is the antibody component, which everyone hears about. You can go commercially have antibodies measured in your body. That fights off the first part of the infection as soon as the virus is recognized. The other part is these T cells, and they remember about the virus, but it takes a few days to get them stimulated to get antibody production and other cells involved in controlling the infection. So that's why we see the first thing that drops off once these vaccines are given is the infection rate goes up, because the initial helpers, these antibodies, you know, have dropped down or whatever. But then people don't end up so much in the hospital, and they don't die nearly as much, 11-fold less than if you're unvaccinated, because those cells are ready to, get invigorated and get out there and protect the person.
That's another argument that a lot of people have against being vaccinated. Well, there's a natural immunity that I will get the disease and then
and that's true. However, the immunity from a mild case of COVID is not very good. The immunity, even after a moderately severe case of COVID, may not last as long. It's just like with the coronaviruses, unfortunately. It's not like measles. You get measles once, you never get it again. That's not true with the coronavirus. So, that immunity also wanes. The immunity you get from a vaccine is much greater than actually from that natural disease. It may sound counterintuitive, but the way the spike protein is presented into the body, the immune system really sort of hyperreacts. And the immunity is consistent between people after they have the vaccine, and it lasts longer than the native immunity. But you do get some protection after you are infected with the real thing.
People forget that you'll hear people say, well, I knew someone who had COVID and it was no big deal. What they forget is what Rob just said. Mild cases give you less immune stimulation. You're more vulnerable going forward. The beauty is that the vaccines work even better when you've had COVID. There's studies that show that you will get a boost in your antibodies 7 days after a vaccine when you've had COVID already, where it would take more than 21 days for a patient who never had COVID.
That sounds crazy. Why is that?
Because your immune system's already primed. You got it once. You've seen the spike protein. We're giving them a shot that gives them more spike protein. They've already got the army, sitting in the barracks ready to come out. And they come out and respond to the vaccine more vigorously than had they never had COVID to begin with. So those who've had a mild case of COVID should look to the vaccine as something that will get them supercharged and really protected.
That's a very good point. If we can get that out, we're going. Can you bring us up to date on what's happening here at Northwestern?
Well, it goes along the lines of what we're talking about with the effectiveness of the vaccines. It's pretty amazing. The data right now is that we have about 80 patients combined in 10 hospitals in the Northwestern system with COVID. We had 580 a year ago. So that is a dramatic decrease from what we used to have.
And what are those patients' characteristics? How many are vaccinated versus unvaccinated?
Most are unvaccinated, absolutely. Wow. Most are unvaccinated. The other thing we should mention about the vaccine is the whole concept of the fourth dose. We have estimated that 2 to 3% of the population meets the criteria of being immunocompromised. They may have a transplant and they're on anti-rejection drugs, or they are on a rheumatoid or biologic drug, or they are on chemotherapy. There was just a study that came out of Hopkins that looked at 30 kidney transplant patients, gave 2 shots of the COVID vaccine to that group. 24 of the 30 mounted no response to them. They gave a 3rd shot. 16 of the 24, still no antibody response. They're about to get a 4th shot. So when people in the public hear about a 4th shot, they're talking about this very slim portion of the population that we studied carefully because we knew they were vulnerable and knew they may not react to the 1st, 2nd, or even 3rd dose of the vaccine. So we're trying a 4th dose. The logic would suggest that if 30 went to 24, went to 16, the 4th dose will help some.
Mm-hmm. We touched on it, but perhaps you can take another swing at monoclonal antibodies. What's happening with that?
Monoclonal antibodies are a tool that is in the toolbox, if you will, to fight COVID. They've really been underused, and they're starting to get more attention the last few months. They are starting to be used in innovative, novel ways we never would have thought of. So a few things have happened. Number one, they continue to kind of mix up what the antibodies are as the variant changes, so that we have specific monoclonals now that work where ones that used to work don't work anymore. We've gone another step where we can give them by injection. That makes the supply a lot more available because you don't have to make a 2-hour appointment for an IV infusion, which takes nursing staff and infusion center staff. So giving them as a shot will be a big deal. we've been doing post-exposure prophylaxis with monoclonals for a while. You're at a nursing home and the person next door to you had a bad case of COVID and you might have been exposed and you're vulnerable. Monoclonals to give you prevention post-exposure, but now we're doing pre-exposure prevention. People who aren't responding to the vaccine, people with leukemia, chemo, transplant patients, and are in a high environment or high risk environment with a lot of COVID cases around them, we're starting to give monoclonals to them before their exposure, just to give them that little extra passive immunity while we wait for the third, fourth, or fifth dose of vaccine to kick in.
Yeah. Are they better than the fourth, fifth dose of vaccines?
Well, I don't know if they're better. They probably are better than the second and third dose. We haven't given fourth and fifth yet, so I don't know. but we do know they wear off. One thing we tell people, though, is that they do give you protection for a while. In fact, it's been advised to not give a COVID vaccine for about 90 days after you get a dose of a monoclonal antibody.
Really?
Well, because you want your immune system to kind of get its chance to see the vaccine new and not have a lot of antibodies already floating around. So.
I think you had something to say about who should get that fourth shot.
Yeah, the fourth shot is really for these severely immunocompromised patients, which are estimated to be 2.7% of the entire population. They are now recommended to get it 6 months after the last dose they had, their third vaccine, which was approved just 2 months ago. And so that will come up in the first quarter of 2022. So those people will be approved to get a fourth shot.
Good.
Yeah, great. They may need a fifth shot. But the one thing about, to back up on the antibodies, these monoclonal antibodies are perfect for these severely immunocompromised patients because they cannot make the antibody. And so we can give them the antibody preventively. And so that's just to echo what Bob said. And now they're coming out as an intramuscular form, so you can just get a shot. You don't have to have the IV infusion. And that's going to make a big impact too.
Yes. Dr. Havey, what children are most at risk from COVID-19?
You know, fortunately, the childhood vaccine has been approved, but you know, every parent of a newborn right up until the age of 12 has been scared because Delta has increased hospitalizations for kids. You know, think about it. A year ago, everybody said, oh, well, if a kid gets exposed to COVID, they're not going to get sick. And then we started seeing that that's not always true. And then Delta changed a lot of that. But the thing parents should have a little bit of reassurance on, most of them, is that there's a number of risk factors that predispose a child from getting into the hospital with COVID, so that most will still do fine. It's true that age still matters. You know, you are more at risk if you're 12 than if you're 28 days old. So every month you get older, you're more at risk for bad COVID and hospitalization. But you're also at risk if you're obese, if you have high blood pressure. Now, we say that easily, but how many kids between age 0 and 12 have high blood pressure? Not many, so they're higher risk. You're at risk if you're diabetic, and you're at risk if you have lung disease, but not asthma. Non-asthma lung disease, we call it, things like cystic fibrosis. Those are the kids who really have to be careful in terms of COVID exposure.
Wow.
Back up on the kid thing a little bit more. Some 8,300 of these kids that are now eligible to take the vaccine have been hospitalized, and 170 of them have died.
Really?
So that's not a small number.
Yeah.
I think we've all become a little numb when we hear, oh, we're down to 70,000 new cases per day. 70,000 cases per day is bad. 1,700 deaths per day in the United States is bad. That's like, 6 airplanes crashing every day full of people. So we have a ways to go. And people have got to take this as serious as possible because we have the tools now to prevent it and to treat it effectively.
We have some people who are afraid even after they get the COVID vaccine. Should they check their antibody levels to see if they're still protected?
You know, it's almost cocktail conversation to go into a room and say, what are your levels? Well, what are your levels? I mean, people like to check the levels, but the reality is that there is not one study published worldwide yet that has agreed on a protective antibody level. Nobody knows what it is. You can measure your level, but we don't know what it means, so we discourage it. And the only time I check levels right now is in a patient who I think may not have responded at all, like a transplant patient, to justify another dose. But otherwise, they should not be checked. And the official position is not to check antibody levels.
I would take it one step further. I think with the commercial antibodies that are available, to make a diagnosis of prior COVID, they're great. To tell you whether you're protected from the vaccine, they're completely worthless. They don't help you. When we do the antibody tests in the laboratories here, it's very specific antibodies. It's not the commercial ones that are out there. And there's usually sets of antibodies, 3 or 6 sets of different antibodies that are looked at. So the commercial antibodies, unfortunately, are a waste of time. And there's no use doing them to see if you have enough protection from the vaccine.
We've gone further at Northwestern as of about 2 months ago, where we removed the list of the regular COVID antibodies from what we call the default. When you go on our record to order a COVID antibody, no longer does the spike protein antibody show up as the test to order. The viral capsid antibody shows up to look if you've had the infection, because we know as clinicians it doesn't help you, and sometimes it misleads you, and it gives the patients a false sense of security.
What about pregnant women? Is the COVID vaccine safe?
Same story as the other side effects. You know, it's been studied. The rate of miscarriages, premature labor, ending up in the neonatal ICU for the babies, all is higher if you get COVID when you're pregnant. So the recommendation is for all pregnant women to get that vaccine.
Last question. I'll come back to you, but let me start with Dr. Murphy. After this conversation, it seems to me that the goal and the real possibility is that we could fold it into our regular visits to the doctor and get a shot once a year.
True.
A vaccine.
It's possible.
Is that how far
that is
away
possible, and we have to get it out of the mass center approach, because that's yet another step. If I'm sitting there talking to you as a patient and you're hesitant, and I can convince you to take the vaccine and we agree, I can't just call the nurse to have her come in and give you a vaccine. That doesn't happen. I have to say, go to Walgreens or CVS and get the vaccine. That's the best way to get it. And that's, you can go through the hospital system, but it's complicated. And we have to eliminate that step. The current administration, with this approval coming, which just happened with the children, is that they want the doctor's offices and the clinics that see kids to be giving the vaccines directly, so they're not sending the family out. And the other thing is to treat the whole family together. If you can convince the parents to vaccinate the kid, they should be vaccinated as well. So this should all be done at a clinical level. That's the direction that we're going.
Right. Flu shot, give me a COVID-19 shot, and what else you got in the office? Would you agree?
Absolutely. One of the important benefits of the new Ryan Family Center for Global Primary Care is that it really promotes the primary care physician and the role of primary care in general health. You have to have an anchor. You have to have a system where patients can access care, where they have a trusted source of truth, where they have a provider, a physician, or other healthcare provider that they can rely upon for all the preventive things as well as the diagnostic and management skills that we provide. It has to start with your local relationship with your physicians, and that's on a local level here in the U.S. And with the new Global Center for Primary Care, we want to look at other countries around the world, enhance the primary care systems of some, and actually learn from some of the primary care systems of other countries.
Any final thoughts, gentlemen?
Yeah, I would say that I've given a lot of these talks at the annual events for the GHI and the Institute for Global Health, and I got some polite applauses when I would say that we were working to become the leader in global health in the United States. There's no question that's what we're going to become.
It's a dynamic process. It's constantly evolving, and we're always learning. And I think the foundation has been set. And our goal is really finish up what's happened with COVID and then work to prevent the next one.
Great. Dr. Murphy and Dr. Havey, it's been my honor to be with you. We have to wrap up this segment, but thanks to you both for offering your insights and thoughts about what lies ahead. We were not able to cover all the questions in the time we had, and we had a few. However, Dr. Murphy and Dr. Havey will put together a summary of answers, and those will be emailed to you in the near future. We want to remind you one final time, if you wish to make a contribution, you can go online to our website, which is displayed on your screen. Thank you all for joining us and for supporting the Robert J. Havey Institute for Global Health, with special appreciation to the generous members of our event host committee this year. We'll see you all in person next year, and this time I mean it.